There are two types of patients that I deal with. As mentioned earlier, pediatric patients make up 90% and adults make up 10%. Typically, pediatric patients are diagnosed by obstetricians during pregnancy, and after birth, they come to my outpatient clinic once the diagnosis of the condition is known from birth. So, as I mentioned before, there are three things to consider. Should we perform surgery? When should we do it? How should we do it? All three of these need to be carefully considered. On the other hand, adult patients often experience recurring pneumonia, or nowadays they are mostly discovered during regular health checkups. Therefore, adult patients are relatively straightforward. You only need to decide how to perform the surgery. However, the two issues mentioned earlier, whether surgery is necessary and when to perform it, are more complex matters. However, some pediatricians hold different opinions. Some individuals in this field have negative views on performing surgery on such young infants who have just been born, are still very young, and show no symptoms. Additionally, due to the low incidence rate of lung cancer in reality, there are opinions that not all cases need surgery. Therefore, to address this debate, the only way to find a solution is through randomized controlled studies. However, if you were in the position of a parent with a newborn baby, would you be willing to participate in a randomized controlled study to decide whether your child should undergo surgery or not? I believe there would be few such parents worldwide. As a result, conducting randomized controlled studies of this kind becomes extremely challenging. So, in cases like this, we rely on indirect evidence for our judgments. First, if pneumonia does indeed occur frequently, we have gathered studies that investigate how often it occurs. All the studies included here are retrograde papers. Looking at the data, the results are very heterogeneous across studies. Some studies report around a 3% occurrence, while others report occurrences as high as 64%. Making judgments based on such studies is very challenging. So, we conducted a survey targeting patients who visit our hospital. We investigated the frequency of pneumonia occurrences among patients who visited the outpatient department of Seoul National University Hospital with congenital lung malformations as their primary diagnosis. We found that up until the age of 1 year, around 20% experienced pneumonia, and by the age of 10, around 80% of patients had experienced pneumonia. Therefore, in our estimation, approximately 90% of patients are expected to have experienced pneumonia at least once by the time they reach adulthood. As a result, we believe that the frequency of pneumonia occurrences is quite high. However, this analysis is subject to bias. Our hospital performs a significant number of surgeries on these patients, so a higher proportion of severely affected patients who require surgery might visit, leading to a higher susceptibility to infections and thus a higher observed frequency. Nevertheless, the patients we encounter in the outpatient setting appear to have this level of risk for pneumonia. And some individuals argue that if pneumonia occurs, why not just undergo surgery afterward? However, from the perspective of a surgeon, I'd like to emphasize that the surgical outcomes are unfavorable when surgery is performed after pneumonia has occurred. One of the patients shown in this slide is an example of such a case. In the left image, you can see a congenital lung malformation before the occurrence of pneumonia. Some parts are cystic, while others are solid, typical of congenital lung malformation patients. However, the image on the right is after pneumonia. You can observe that the entire lung lesion has turned into consolidation after pneumonia. Of course, in some cases, antibiotics can lead to recovery similar to the pre-pneumonia state, but not all cases respond so well to treatment. Performing surgery in such a condition increases the difficulty of the procedure. Like as operating on a large lung tumor, it becomes a technically challenging surgery, and even if the resection is successful, removing such a large mass from the body is extremely difficult. These kinds of large consolidations were common during the late 2000s H1N1 pandemic, so during the COVID pandemic as well, there were concerns about an increase in such cases, but it seems that such patients did not increase significantly this time. Perhaps even very young children were wearing masks and prevented such occurrences. And I would like to emphasize that undergoing surgery after suffering from pneumonia is incredibly challenging. This study is a retrospective study that compares cases where surgery was performed before the occurrence of pneumonia with cases where surgery was performed after pneumonia. In cases where surgery was performed before pneumonia, complications occurred in around 10% after the surgery, while in cases where surgery was performed after pneumonia, complications occurred in about 31%, indicating an approximately threefold increase in the risk of complications. Therefore, the results reported align with the first-hand experiences of surgeons. Next, I will talk about lung cancer. The primary reason for performing surgery on patients without symptoms is the potential occurrence of lung cancer. However, as of current knowledge, it is understood that around 1% of patients with congenital lung malformations develop lung cancer. Nevertheless, this low percentage of 1% mostly stems from patients undergoing surgery before lung cancer develops. The frequency of lung cancer occurrence could become 30% or 50% if left untreated, but this cannot be determined without performing surgery. The most common type of lung malformation is pulmonary blastoma. This pulmonary blastoma is typically discovered in an advanced stage as the patient grows older. As mentioned earlier, lung cancer arising from congenital lung malformations is known to most commonly manifest as pulmonary blastoma and adenocarcinoma. Adenocarcinoma is frequently observed in cases of type 1 congenital pulmonary airway malformation. This study reports around 20 cases so far. However, according to more recent research, over 50 cases have been reported globally. Mucinous type adenocarcinoma is typically the most common. Pulmonary blastoma has been extensively reported, with hundreds of cases documented. Pulmonary blastoma is classified into three distinctive types, type 1 being cystic, type 2 being cystic and solid, and type 3 being solid. However, there is an observed trend where type 3 is more commonly discovered when diagnosed at older age. It is speculated that the progression may involve transitioning from type 1 to type 2, and finally to type 3. Additionally, it has been reported that as the progression advances to the solid type, the long-term survival rate decreases. Therefore, there is a general consensus that if pulmonary blastoma is suspected, surgery should be conducted promptly. This patient is someone I recently operated on. They visited the outpatient department with a cystic lesion at 19 months of age. While waiting for surgery, the patient's condition deteriorated, prompting suspicion of pneumonia, leading to an emergency admission. Despite antibiotic treatment for pneumonia in the cyst, there was minimal response. As the appearance seemed peculiar and not indicative of pneumonia, a chest MRI was conducted by the pediatrician. The MRI revealed a near-complete transformation into a solid form. This change occurred in just 5 months. Subsequently, an urgent operation was performed, and a diagnosis of pulmonary blastoma was made. Thus, I believe the assumption that we can effectively understand and control the progression of lung cancer is not accurate. This is a condition where waiting for symptoms to arise over several years could lead to the patient's death. This patient is also a case of pulmonary blastoma. However, during the initial outpatient visit, this patient exhibited features of pulmonary blastoma with an already present huge cyst and multiple solid lesions. During the surgery, multiple pleural metastases were discovered on the surgical field. At that time, there was much deliberation on how to proceed, but since the outcome of performing only open and closed surgery was anticipated, pleuropneumonectomy was carried out. Nevertheless, the patient succumbed to the progression of lung cancer 8 months later. Therefore, I firmly believe that the risk of lung cancer should never be underestimated. So, in conclusion, considering the risk of recurrent pneumonia and lung cancer even in asymptomatic patients, my opinion, along with the opinions of many other surgeons, is that surgical removal is advisable.